Homeostasis and bleeding. Homeostasis means stopping of hemorrhage from injured blood vessels. It's similar to a building. It needs blood vessel wall, platelets, and coagulation system. It's divided into extrinsic and intrinsic pathway. Extrinsic pathway, rapid process, triggered by trauma, releasing of thromboplastin factor 3, activation of factor 7, then common pathway. Intrinsic pathway, roughness of blood vessels, activation of factor 12, activation of factor 11, activation of factor 9, then activation of factor 8, then the common pathway. The common pathway, activation of factor 10, then factor 2, prothrombin to thrombin, then factor 1, fibrinogen to fibrin, then the fibrin with factor 13 will produce stabilized fibrin or clot. Homeostasis disorders are classified into three groups: vascular, platelets, and coagulation disorders. Vascular disorders or vascular purpura, due to acquired causes or congenital such as Ehlers-Danlos syndrome or hereditary telangiectasia. Ehlers-Danlos syndrome, increased skin elasticity and capillary fragility, while hereditary telangiectasia, it's called Osler-Weber-Rendu syndrome, rare condition in which there are thin wall dilatations in the wall of capillaries, leading to recurrent hemorrhage and anemia. Acquired causes of vascular disorders are menopause, malignancy, senile purpura, scurvy, vitamin C deficiency, iatrogenic, steroids and sulfonamides, infection, meningitis, typhoid, infective endocarditis, idiopathic purpura simplex, especially in females over limbs and trunks, It resolves without treatment. Immune, vasculitis, SLE, Henoch line purpura or anaphylactoid purpura. We're going to explain it later. Then we have platelet disorders due to defect, whether in the platelet number or platelet function. Platelet number, it's called thrombocytopenia, when platelet count is less than 150,000 per centimillimeter. It's due to decreased production, increased destruction, or increased consumption. Increased consumption, such as disseminated intravascular coagulation DIC or thrombotic thrombocytopenic purpura TTP. Increased destruction of platelets, idiopathic, immune thrombocytopenic purpura ITP, immune causes SLE, infections, Epstein-Barr virus, HIV, gram-negative septicemia, or hypersplenism. Decreased production of platelets, bone marrow failure, bone marrow infiltration such as leukemia, and vitamin B12 or folic acid deficiency. Platelet function, thrombocythemia, hereditary or acquired, hereditary, von Willebrand's disease, reduced production of von Willebrand factor, Glanzmann's disease, platelets are unable to aggregate. Acquired causes are chronic renal failure, unknown mechanism, chronic liver diseases, vitamin C deficiency, scurvy, iatrogenic, antiplatelets, aspirin, heparin, antibiotics such as penicillin or cephalosporins. Non-thrombocytopenic purpura means vascular purpura plus thrombocythemia. Coagulation disorders, congenital, acquired, congenital hemophilia A, B, afibrinogenemia, and dysfibrinogenemia. Hemophilia A is a classic hemophilia due to deficiency in factor 8, while hemophilia B, Christmas disease, factor 9 hemophilia. Acquired, liver cell failure, vitamin K deficiency, DIC, drugs such as anticoagulants. Tests for purpura and coagulation system: Hess test, bleeding time, clotting time, activated partial thromboplastin time, prothrombin time, and thrombin time. Hess test, capillary fragility test. It detects vascular purpura, but it may be positive in other types of purpura. Bleeding time, 2 to 7 minutes. It's obsolete. Small incision is made and the wound is wicked with filter paper every 30 seconds until the fluid is clear. Prolonged in all types of purpura. Clotting time, 5 to 10 minutes, indicator of intrinsic pathway. It's not sensitive because it takes from 4 to 5 minutes just to activate factor 12. Activated partial thromboplastin time or APPT or PTT, normally from 30 to 40 seconds, used to evaluate intrinsic coagulation system, used to monitor heparin therapy, prolonged in heparin, defect in intrinsic pathway such as hemophilia DIC or von Willebrand disease. Prothrombin time, normally from 10 to 14 seconds, measured by adding tissue thromboplastin and calcium to the patient's plasma to activate the extrinsic pathway. It's used to evaluate extrinsic coagulation system, monitor oral anticoagulant therapy, prolonged in oral anticoagulants, liver diseases, deficiency in vitamin K or DIC. INR, International Normalized Ratio, the patient divided by the control PT. Normally it's from 0.8 to 1.2. Therapeutic INR is 2 to 3. Thrombin time, normally 10 to 14 seconds, performed by adding thrombin to the patient's plasma. It measures the conversion of fibrinogen to fibrin prolonged in afibrinogenemia, dysfibrinogenemia, DIC, and heparin. Purpura. Definition: the purpura is multiple spontaneous capillary bleeding in the skin and mucous membrane due to defect in platelets or in the wall of blood vessels. Etiology: vascular disorders, platelet disorders that we have explained. Clinical picture: bleeding, spontaneous and of short duration. For skin, we have multiple petechiae or purpura without raised edge in platelet disorders, with raised edge in vascular disorders, and we have small ecchymosis which may occur. Mucous membrane, gum bleeding, bleeding per orifices, epistaxis, menorrhagia, hematemesis, internal organs, cerebral, retinal hemorrhage, anemia, and features of the cause. We have to compare between petechiae and ecchymosis. Petechiae, intradermal hemorrhage, few millimeters, not raised, disappear without color changes and not related to the site of trauma, while ecchymosis, subcutaneous hemorrhage, few centimeters, raised with color changes and usually related to the site of trauma. Henoch line purpura or anaphylactoid purpura or allergic purpura, type of small vessel vasculitis which occurs mainly in children from 2 to 8 years. This is the age peak. It is the most common cause of non-thrombocytopenic purpura, and remember, non-thrombocytopenic purpura means thrombocythemia plus vascular purpura. Clinical picture: diagnosis of Henoch-Schönlein purpura depends on clinical findings and history because there is no specific laboratory test for the disorder. Skin, 100% is affected. Palpable purpuric rash, especially over the buttocks and extensor surface of the legs. Joints, 75%. Migratory polyarthritis, particularly knees and ankles. Abdominal pain, GIT bleeding due to mesenteric vasculitis. Renal involvement, this is the worst prognosis. Focal glomerulonephritis or asymptomatic proteinuria with hematuria. Investigations: all investigations of bleeding tendency are normal except for His test, which may be positive. Platelet count and function are normal. Elevated serum IgA is suggestive. Skin biopsy, IgA deposits. Treatment and prognosis: chronic renal failure in 10% of the cases. Spontaneous resolution within a month is the commonest outcome in children. Steroids may improve the joints and GIT manifestations. Then we have immune thrombocytopenic purpura, ITP, autoimmune disorder in which there is destruction of the peripheral platelets by IgG autoantibodies. It is the most common cause of thrombocytopenia. Types: we have ITP in children and ITP in adults. In children, it is the acute type. The condition is usually less than 6 months. In both genders, it's equal. Frequently precipitated by viral infection, usually self-limited in most cases, 90% of the cases. IgA level is normal. ITP in adults, the condition is usually chronic with remissions and relapses. It may be associated with other autoimmune disorders such as SLE, and it's more in females than males. IgA is less than normal. Clinical picture: general manifestations of purpura, as previously explained. Spleen is not palpable, and if enlarged, never hugely enlarged. Investigations: blood examination, thrombocytopenia, platelet count is less than 150,000 per centimillimeter and maybe less than 20,000 per centimillimeter in severe cases. Other counts are usually normal except for occasional mild anemia, which can be explained by bleeding or associated hemolysis. Platelet antibodies are present in most cases, 65% of chronic cases. Bleeding time is prolonged. Coagulation tests, CT, PT, APTT, and TT are normal. Bone marrow, the most important diagnostic test, normal or increased megakaryocytes with defective budding. Diagnostic criteria of ITP: isolated thrombocytopenia, no systemic illness, other hematopoietic cell lines are normal, spleen not palpable, normal bone marrow with normal or increased megakaryocytes. Treatment: most children don't require treatment because it's self-limiting in most cases. Just follow up for the fear of intracerebral hemorrhage. Prednisone decreases platelet antibody production and interferes with phagocytosis. The dosage is 2 mg per kilo per day orally for 2 weeks. About 80% of the cases will respond and the platelet count will usually return to normal. Splenectomy is the curative therapy for ITP as spleen is major site for platelet destruction. Indications: who fail to respond to prednisone or requiring high doses of prednisone. Precautions: pneumococcal vaccine before and long-acting penicillin after splenectomy. Immunosuppressive agents such as azathioprine, cyclophosphamide, or vincristine. Indications: if no improvement after splenectomy, and may be used with prednisolone to obtain acceptable platelet count. IVIG 1 gram per kilo for 1 or 2 days, but it's very expensive, non-toxic. The effect lasts only for 1 to 2 weeks. It blocks surface receptor of platelets, leading to competitive inhibition of antiplatelets antibodies. Indications: refractory to other treatments, who require urgent improvement for surgery and pregnancy. Platelets transfusion. Using of platelet transfusion in ITP is bad medicine because they are destroyed by the antiplatelets autoantibodies, but they are maybe indicated in life-threatening conditions. Danazol, androgen, increasing platelet count. It may be used as an alternative to prednisolone or in combination with prednisolone. The dosage 400 to 800 mg per day for 1 to 3 months. Side effects: virilization, weight gain, and hepatotoxicity. Then we have coagulation disorders. Types of coagulation disorders: hemophilia A, B, C, and parahemophilia. Deficiency in factor 8A, 9B, 11C, 5 parahemophilia. Hemophilia A, congenital coagulation disorder caused by defective production of factor 8, X-linked recessive, and as a rule, only males are affected. So if a female carrier has a son, he has 50% chance of having hemophilia, and a daughter has 50% chance of being a carrier. All daughters of men with hemophilia are carriers, but the sons are normal. Degree: mild when factor 8 is more than 5%, moderate when it's from 1 to 5%, severe if it's less than 1%. Clinical pictures: the disease affects only males. Bleeding since birth, usually by trauma during circumcision. Factor 8 received from the mother is enough for just 1 week. Ecchymosis, whether spontaneously or after minor trauma. Intramuscular hematoma following intramuscular injections. Hemarthrosis, spontaneous bleeding into joints, knees, then elbows, then ankles, then hips, then wrists. Fibrosis and deformity, internal organs, GIT and CNS bleeding. Epistaxis, bleeding gum. Hematuria, hematemesis. Excessive bleeding after minor surgical procedures. Neuropathy may occur due to pressure from hematoma. Hepatitis B, C, and HIV may occur due to repeated blood transfusion. Investigations: APTT is prolonged, while PT and bleeding time or von Willebrand factor are normal. Platelet count normal. Reduced level or activity of factor 8. Radiological examination of joints in hemarthrosis. Treatment: general measures: avoid intramuscular injections, avoid trauma, avoid antiplatelet drugs such as aspirin, vaccinate against hepatitis B virus. Factor 8 concentrates are the cornerstone of the management. Desmopressin, synthetic vasopressin, it increases the release of factor 8. Fresh blood transfusion in severe bleeding. Von Willebrand's disease, the von Willebrand factor, it plays a role in platelet adhesion to damaged subendothelium as well as stabilizing factor 8 in plasma. So its deficiency leads to platelet dysfunction and hemophilia, and the treatment is like hemophilia. Laboratory diagnosis like hemophilia, but the bleeding time is prolonged with impaired platelet function tests. Disseminated intravascular coagulation or DIC, acquired coagulopathy in which there is widespread fibrin formation leading to consumption of platelets and coagulation factors and activation of fibrinolysis. Etiology: endothelial damage, activation of intrinsic pathway, whether due to infection, gram-negative bacteria such as meningococci, or gram-positive bacteria, pneumococci, or anaerobes, TB, and viruses. Vascular, such as malignant hypertension or myocardial infarction. Trauma: release of tissue factor, activation of extrinsic pathway, whether due to crush injury, thermal injury. Leukemia, especially acute promyelocytic leukemia, M3. This is an important MCQ note. Obstetric complications: amniotic fluid embolism, retroplacental hemorrhage, IUFD, and preeclampsia. Clinical picture, DIC leads to both bleeding and thrombosis. Clinical picture of the cause, bleeding due to consumption of coagulation factors, ecchymosis, petechiae oozing from venipuncture sites, and post-operative bleeding, thrombosis, organ failure, renal dysfunction, cerebral dysfunction, acute respiratory distress syndrome, ARDS, and skin necrosis. Clinical types, acute uncompensated DIC, bleeding more than thrombosis, rapid, extensive activation of coagulation and fibrinolysis with depletion of coagulant factors, while in chronic compensated DIC, thrombosis is more than bleeding with slow consumption of coagulation factors. Investigations, prolongation of all coagulation tests PT or TT or APTT, fibrin degradation products and D-dimers are high, fibrinogen is low, and it's an important diagnostic laboratory feature because only few other disorders such as congenital hypofibrinogenemia or severe liver diseases will lower the fibrinogen level. Platelet count is low, especially in acute DIC. Microangiopathic hemolytic anemia in 25% of the cases show fragmented RBCs. Treatment, highly controversial. Treatment of the cause if possible, antibiotics for infection, replacement therapy, platelet transfusion, fresh frozen plasma, heparin. Its use is controversial because it may accelerate bleeding. Antifibrinolytic, epsilon aminocaproic acid. Its use is controversial because it may accelerate microvascular clotting. Then we have vitamin K deficiency. Vitamin K deficiency. Vitamin K is found in green leafy vegetables and synthesized by GIT flora. It's a fat-soluble vitamin, so it needs bile for its absorption. It's mostly acquired for blood coagulation because it's responsible for carboxylation of factors 1972, 2, 7, 9, and 10, and also to maintain proper bone density. Etiology, diminished intake. It's very rare, but it's found in infants because of the low level of vitamin K in breast milk and low bacterial synthesis. Decreased production by normal flora, as seen as in broad-spectrum antibiotic use or in premature infants. Diminished absorption in obstructive jaundice and malabsorption syndrome. Intake of vitamin K antagonists such as oral anticoagulants, salicylates, and barbiturates. Chronic liver disease, particularly primary biliary cirrhosis. Clinical picture such as it's like hemophilia. Investigations, bleeding time and platelet count is normal, while the PT and PTT are prolonged. Treatment, vitamin K 10 mg IV, fresh frozen plasma or concentrated vitamin K dependent clotting factors in severe hemorrhage, and treatment of the cause by stopping oral anticoagulants. How to approach a case of bleeding tendency. Clinical approach, etiology of bleeding, as we explained. Clinical features, history and examination. You need to ask about the drug history, family history, if there is evidence of a disease associated with hemorrhagic tendency, any form of hemorrhage, how long and how frequent is the hemorrhage, is it ecchymosis or purpura, is there gum bleeding, has the patient experienced prolonged bleeding after trauma, dental extraction, childbirth, or surgery. Then we're going to compare between vascular disorders, platelet disorders, and coagulation disorders. Vascular disorders, petechiae with raised edge. Platelet disorders, petechiae without raised edge, bleeding gums, epistaxis, or more serious life-threatening hemorrhage, small ecchymosis. Coagulation disorders, hemarthrosis, hematomas, and ecchymosis. Vascular disorders and platelet disorders have good effect of compression, while coagulation disorders, poor effect of compression. Vascular disorders and coagulation disorders, the bleeding is usually post-traumatic, while platelet disorders, the bleeding is usually spontaneous. Vascular disorders, all investigations of bleeding tendency are normal except for Hess test. Platelet count and function are normal. While in platelets disorder, normal PT and APTT with prolonged bleeding time. Coagulation disorders, normal bleeding time, but with prolonged PT or APTT or both, with assay of coagulation factors because it's important. So if we're gonna make investigations for a case of bleeding, first we're gonna ask for CBC and see the platelet count. If decreased less than 150,000 per centimillimeter, then this means thrombocytopenia. We're gonna go for bone marrow examination to detect the cause. If it's normal, we're gonna go for bleeding time. If normal, then we're gonna go for the coagulation defect by the assay of coagulation factors. with prolonged PT or APTT or both. If it's prolonged, if the bleeding time is prolonged, then we're gonna go for platelet function test. If it's low, then it's a thrombocythemia. If it's normal, then it's vascular purpura. Bone marrow examination is the definitive investigation in all patients with moderate or severe thrombocytopenia. Decreased megakaryocytes mean bone marrow failure, while normal or increased megakaryocytes means ITP and hypersplenism. Then we have polycythemia or erythrocytosis. It means increase in red blood cell count and hematocrit value. We have three types: polycythemia rubra vera, secondary polycythemia, and relative polycythemia. Relative polycythemia or pseudopolycythemia, it's due to decrease in plasma volume with normal RBC's mass due to diuretic therapy or dehydration. Polycythemia rubra vera is primary myeloproliferative disorder. Secondary polycythemia due to increased production of erythropoietin in kidney, polycystic kidneys, renal artery stenosis, cortisone therapy, Cushing syndrome, cancer, paramalignant syndrome in lung cancer and hepatoma, chronic hypoxia from COPD, cyanotic congenital heart diseases. Clinical picture of polycythemia vera: plethora, engorged retinal veins, blood hyperviscosity leading to thrombosis, hypertension, congestive heart failure, low cardiac output syndrome symptoms such as headache, dizziness, blurred vision, and fatigue, palpable spleen, pruritus especially following warm shower, related to histamine release due to basophilia. Complications: thrombosis. Over time, polycythemia vera may convert to myelofibrosis or to chronic myeloid leukemia. Investigations: CBC, increased RBC's count more than 6 million per centimeter, RBC's mass more than 36 milli per kilo for males and more than 32 for females, hematocrit value increased, white BC's and platelets increased in polycythemia vera but rare in other causes of polycythemia, decreased ESR, arterial oxygen saturation to detect chronic hypoxia, bone marrow examination, normal in secondary polycythemia, with hypercellularity of all bone marrow elements, especially in erythroid cells in polycythemia vera. Others: uric acid elevated, vitamin B12 elevated because of the increased levels of transcobalamin 3 secreted by the white BCs. The diagnostic criteria of polycythemia rubra vera: A1, 2, 3, 4, B1, 2, 3, 4. And for the diagnosis of polycythemia vera, we need A1 plus A2 plus A3 or A4, or A1 plus A2 plus 2 of B's. A1 is for increased red blood cell mass, more than 36 milli per kilo in males and more than 32 in females, or hematocrit value more than or equal to 60%. A2, normal oxygen saturation to exclude hypoxia. A3, palpable splenomegaly. A4, abnormal bone marrow karyotype. B1, thrombocytosis, platelet count more than 400,000. B2, total leukocytic count more than 12,000. B3, high leukocytic alkaline phosphatase. B4, reduced serum erythropoietin. Treatment of polycythemia vera: supportive treatment, adequate fluid intake to avoid dehydration, allopurinol for hyperuricemia, repeated vinsection to keep the hematocrit value below 50%, hydroxyurea, myelosuppressive agent, radioactive phosphorus P32 and busulfan. Treatment of complications: aspirin to prevent thrombosis. Myeloproliferative syndromes. Definition: clonal abnormalities of hematopoietic stem cells, polycythemia vera, myelofibrosis, essential thrombocytosis, chronic myeloid leukemia. Essential thrombocythemia. If we're going to compare between essential thrombocythemia, polycythemia vera, myelofibrosis, and chronic myeloid leukemia. For chronic myeloid leukemia, elevated white blood cell count, normal red cell morphology, and normal hematocrit value with normal or elevated platelet count. Myelofibrosis, normal or increased or decreased white blood cell count, and the same goes for the platelet count, but normal or decreased hematocrit value with abnormal red cell morphology. Then we have the polycythemia vera, normal or elevated white blood cell count or platelet count with increased hematocrit value and normal red cell morphology. Essential thrombocythemia, the white blood cell count is normal or elevated, hematocrit value normal, platelet count elevated, and red cell morphology is normal. Essential thrombocythemia is a myeloproliferative disorder of unknown etiology. There is excessive production of platelets, more than 400,000 per centimillimeter. Epidemiology 1.5 per 100,000 with median age of 60 and more in females. Pathogenesis, clonal process with megakaryocyte growth factor called thrombopoietin, promoting proliferation and maturation of megakaryocytes. Clinical picture, more common in old age females. It may be asymptomatic, diagnosed by accident. Headache, visual symptoms, increased risk of thrombosis, venous or arterial, pulmonary embolism or stroke. Erythromyalgia, burning sensation felt in hands or feet associated with skin erythema. Bleeding tendency due to platelet dysfunction is infrequent. Mild splenomegaly, but it may not be palpable by time secondary to splenic infarction. It may be associated with other myeloproliferative disorders such as polycythemia vera, chronic myeloid leukemia. Investigations, platelet function test usually impaired. Bone marrow biopsy, hypercellular with excessive megakaryocytes. Blood fill may show abnormal large platelets and megakaryocytes. Persistent increase of platelet count not associated with iron deficiency. Treatment, platelet spheresis, platelet lowering agent, hydroxyurea, bisulfan, and interferons, aspirin to reduce thrombotic risk. And it's often difficult to differentiate between essential thrombocythemia and reactive secondary causes of thrombocytosis, so it's necessary to treat any potential cause of secondary thrombocytosis which may be present and see what happens to the platelet count over months. Causes of secondary or reactive thrombocytosis: increased production or decreased destruction post-splenectomy, hyposplenism, or increased production in iron deficiency, infection, TB, stress, trauma, surgery, infarction, hemorrhage, hemolytic anemia, inflammatory diseases as ulcerative colitis, myelodysplastic syndromes, clonal disorders characterized by ineffective hematopoiesis and peripheral cytopenia. Some patients may progress to develop acute leukemia. It affects elderly patients and may be discovered accidentally or present with anemia and or bleeding. The disorders are usually idiopathic 70%, but may be seen after cytotoxic chemotherapy. CBC, macrocytic anemia, plus or minus neutropenia, plus or minus thrombocytopenia, plus or minus monocytosis. FAB classification: RA, RARS, RAIB, and chronic myelomonocytic leukemia. RA, refractory anemia. RARS, refractory anemia with ringed sideroblast. RAIB, refractory anemia with excess blast. Chronic myelomonocytic leukemia, peripheral blood monocytosis. And then we have the multiple myeloma. Myelomatosis or multiple myeloma definition: it's a clonal B-cell malignancy characterized by proliferation of plasma cells which accumulate mainly within the bone marrow and usually secrete paraprotein, mainly IgG or IgA, but rarely IgD. Clinical picture: the clinical manifestations are due to bone destruction, renal impairment, hyperviscosity, replacement of bone marrow. Multiple myeloma is a disease of elderly, appears usually around the age of 60 years and more common in males. Bone destruction, most present with bony pain, usually in the back, 75% of the cases. Pathological fracture, spinal cord compression, hypercalcemia, which presents as polyuria, nausea, depression, and conjunctivitis. Replacement of bone marrow or bone marrow failure, anemia, recurrent infections, bleeding. Renal impairment, chronic renal failure due to hypercalcemia, hyperuricemia, amyloid deposition. Hyperviscosity, leading to fatigue, headache, blurring of vision. Investigations: ESR always high. Normocytic, normochromic anemia, and may show rouleau formation. Serum protein electrophoresis, finding of paraproteins. Bone marrow examination, plasma cell infiltration. Urine examination may be positive for Bence-Jones proteins. X-ray bone, pathological fracture or lytic lesion. Biochemical, elevated urea, creatinine, and calcium with normal alkaline phosphatase. Diagnostic criteria for multiple myeloma: at least one major plus one minor criteria or three minor criteria. The major criteria are plasmacytoma on tissue biopsy, maroplasmacytosis more than 30%, monoclonal protein, IgG more than 3.5 gram per deciliter, IgA more than 2 gram per deciliter, and Bence-Jones protein more than 1 gram in 24 hours. Minor criteria: maroplasmacytosis from 10 to 29%, monoclonal proteins present but less than the above levels, lytic bone lesions, and decrease in uninvolved immunoglobulins. Suspect multiple myeloma in patient exceeding 50 years with bone pain, anemia, recurrent infection, renal impairment, hypercalcemia, neuropathy, and elevated ESR. Treatment, supportive therapy, and specific therapy. So supportive therapy, bone diseases, local radiotherapy for localized pain and bisphosphonate, allopurinol to prevent urate nephropathy, antibiotics for infections, anemia, blood transfusion, erythropoietin, hyperviscosity syndrome, plasmapheresis. Specific treatment, melphalan, prednisolone, combination chemotherapy, VAD regimen, vincristine, adriamycin, and dexamethasone. Spleen. Causes of splenomegaly: infections, blood disorders, autoimmune disorders, circulatory disorders, infiltration. Infiltration, we have amyloidosis and Gaucher's disease, genetic disease in which lipid accumulates in cells and organs. It's the most common lysosomal storage disease. Circulatory disorders, portal hypertension, portal vein thrombosis. Autoimmune disorders, SLE, rheumatoid arthritis, Feltes syndrome. Blood disorders, chronic hemolytic anemia, such as autoimmune hemolytic anemia, hereditary spherocytosis, thalassemia. Myeloproliferative disorders, such as CML, myelofibrosis, polycythemia rubra vera, essential thrombocythemia. Lymphoproliferative disorders, such as CLL, most lymphomas, and hairy cell leukemia. Infections, we have viral, bacterial, protozoal, or parasitic. Viral, Epstein-Barr virus, cytomegalovirus, hepatitis. Bacterial, TB, Salmonella, Brucella. Protozoal or parasitic, bilharziosis, malaria, toxoplasmosis, leishmaniasis. Then we have differential diagnosis for just palpable spleen. It includes typhoid, hepatitis, brucellosis, infective endocarditis. Differential diagnosis for huge splenomegaly, CML, CLL, Kala-Azar or leishmaniasis, myelosclerosis, polycythemia, hairy cell leukemia, malaria, Gaucher's disease, myelofibrosis, bilharziosis. Then we have hypersplenism. Its definition, excessive splenic function which leads to accelerated destruction of one or more of the three elements of the blood. Causes, primary, secondary. Primary, no cause of splenomegaly is detected. Secondary, on top of enlarged spleen with detected cause, but hypersplenism can occur in absence of splenomegaly as in chronic ITP. Mechanism, mechanical obstruction inside the splenic bulb, sequestration, formation of autoantibodies against the blood cells, secretion of certain agents which inhibit release of cells from bone marrow. Diagnostic criteria, splenomegaly, peripheral cytopenia in one or more cell lines, normal or hypercellular bone marrow, improvement after splenectomy, and radioactive RBCs phagocytosed inside the spleen. Indications of splenectomy, blood diseases, hypersplenism, bilharziosis lymphoma, spherocytosis, ITP after failure of steroid therapy. Traumatic, second commonest indication. Others, tumors, cysts, abscess, or part of other operations such as radical gastrectomy or radical pancreatectomy. Hematological and immune changes after splenectomy, decreased IgM levels, neutrophilia in response to infection, Howell-Jolly bodies, nuclear remnants in the red cells, increased platelet count, and occasional spherocytes with increased aniso and poikilocytosis. Causes of hyposplenism, 5S, and I'm not responsible for this mnemonic, splenectomy, sickle cell disease, celiac disease, congenital asplenism, essential thrombocythemia. Infection, prophylaxis necessary in hyposplenism, pneumococcal vaccine. It's required at least 2 weeks before planned splenectomy, and if the operation is unplanned, it should be given as soon as possible afterwards. Meningococcal and H influenza vaccines, post-operatively, prophylactic long-term penicillin V, 500 mg each 12 hours. Blood transfusion. Indications, to restore blood volume, acute hemorrhage, external or internal, operative and post-operative replacement, severe burns, and to provide deficient blood elements, packed RBCs in patient with severe anemia, fresh frozen plasma, hemophilia, liver cell failure, DIC, platelets, concentrate, thrombocytopenia, acute leukemia, cryoprecipitate hemophilia, albumin hypoalbuminemia, and test for the blood ABO antigen, Rh antigen, Combs test. Complications, we have acute within the first 72 hours or delayed after 72 hours. The delayed complications are delayed hemolysis, post-transfusion purpura, iron overload, transmission of diseases such as AIDS, HBV, HCV, brucellosis, cytomegalovirus, and malaria. Complications in the donor, anemia, complications of repeated venous puncture. The acute complications which occur within the first 72 hours, there are acidosis, thrombophlebitis at site of injection, air embolism, bleeding tendency due to dilution of patient blood platelets, deficient clotting factors, hypothermia, circulatory overload, heart failure, hyperkalemia, hypocalcemia, ARDS, acute respiratory distress syndrome, allergic reaction, febrile non-hemolytic reaction due to presence of leukocyte antibodies against the donor leukocytes, and finally hemolytic transfusion reaction due to incompatible blood transfusion leading to destruction of donor RBCs by the recipient antibodies. Clinical picture: fever with rigors, headache, malaise, anorexia, فاهم, chest pain, dyspnea, nausea and vomiting. Signs: fever, tachycardia, cyanosis, hypotension, oliguria, hemoglobinuria, and later on renal failure. If patient is under anesthesia or comatose, incompatibility is suspected by progressive unexplained hypotension and unexplained tachycardia. Treatment for hemolytic reaction: stop transfusion, IV fluid, alkalinization of urine. Red cell transfusion, acute blood loss. Healthy persons usually tolerate up to 30% blood loss without transfusion. If hemoglobin is more than 10 grams per deciliter, transfusion is rarely indicated. Hemoglobin from 7 to 10, transfusion based on clinical symptoms unless the patient has severe medical problems such as ischemic heart diseases, severe COPD. If hemoglobin is less than 7 grams per deciliter, transfusion is usually needed. Chronic anemia, RBC transfusion formula: volume of cells equal total blood volume of the patient times the difference between desired hematocrit value and the actual hematocrit divided by the hematocrit of the transfusion product, where the total blood volume is 70 ml per kilo for adults, 8 ml per kilo for children. The hematocrit of the packed red RBCs is approximately 70%, and the whole blood is approximately 40%. And this concludes our part for today.